We'll just start the last session in this hall for this conference and then probably have quick lunch and go back. So we had a good conference till now. And this session is a little change. Many of you would have attended our previous session. So we're not talking theory here. We have tried to keep this section practical. So one of the important thing is, since you are here, whatever questions you have, please do ask. That's the whole purpose. They are good 15-20 minutes. And anyone has got any questions, even unrelated to this session, but related to NABH, please go ahead and ask. So that's a format. The last part is a free thinking. You can ask any questions which you have even not covered. Right. So the first talk in this session will be a keynote address by Dr. Mohana Majumdar. And its title is Access, Audit, and Accredit for Quality and Patient Safety. Afterwards, we'll start our NABH talks. Thank you.
One and all. At the outset, I would thank AIOS and Dr. Gagan for including me in this session. Well, I take care of the quality assurance cell, that is IQAC, in a medical college in Nagpur. And actually, yes, even medical colleges now, it has become essential for them to undergo accreditation. So there's NMC as well as NAC now. So what is accreditation? It is a public recognition or a stamp. So you can use their logo once you have demonstrated to the external assessors that you have a particular level of performance or a standard in your healthcare practices. So life keeps testing us, and even at this stage, we have to pass this test. In our MBBS, we take a pledge, which is the Hippocratic Oath. Now they are going to change it into this Maharishi Charak Shapath, where we vow that patient safety is of utmost importance, and that all our energies is going to be focused on curing the disease. NABH aims for the same, but WHO says that 1 in 3 people report negative experience of their healthcare system, such as disrespectful care, short consultations, or long waiting times. So we are kind of losing trust in our patients. This could be because of the negligence of a handful of doctors, but the patient-doctor relationship is going down to the extent that the patient's relatives are assaulting the doctors. This is an incident just happened a couple of years back in Dhule Civil Hospital, where an orthopedic surgeon was assaulted. He had multiple orbital fractures. So what can we do? Either we take self-defense classes, which I'm telling you is also important. In fact, in medical colleges, we now have lectures on self-defense for the doctors. But most important, we can actually improve and work on the improvement of quality of healthcare so that the doctor-patient relationship improves. So what is quality of care? It is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes. So for ophthalmologists, it's obviously giving 6/6 vision. And so it should be effective, safe, and people or patient-centered. So with this in mind, the government of India pioneered in a venture and established the Quality Council of India, and so that they can maintain the ecosystem of healthcare. And NABH is a constituent board or one of the constituents of the Quality Council of India. It is an institutional member of the ISQA. It is a member of the Accreditation Council of ISQA, and it is on board of Asian Society for Quality in Healthcare. So of course it has the accreditation committee, and it has a strong technical committee, because we have to apply online. All our documents are to be uploaded through the online process. So they have a strong committee there, and they have the administration where there is an assessor management committee, the risk management and improvement committee, the complaints committee, and a panel of assessors. So 2 important benefits I've already mentioned, that is to improve the trust in the patient and to actually improve the quality of patient care. And of course, it creates a roadmap for standardization. So there are 3 levels. So every time you can improve your level, then it improves the patient satisfaction levels, and it creates awareness in about the rights in the patients in the right way and not through Google. Then it provides for continuous learning, good working environment. It also leads to leadership qualities, and it improves it enhances the career of the team that is working for NABH. It provides an objective system of empanelment by insurance and other third parties, so this is extremely important. For example, CGHS, it is essential, and in fact, in our medical college, it is as per the NABH, we get the amount, the reimbursement. And of course, as I said, you can put a stamp or the logo, and once that logo is seen on your website or any other social media platform, it helps in enhancing medical tourism. So any clinic or any hospital can apply, irrespective of the size. You have to visit the website and get yourself registered and then follow the guidelines. The fees for eye care organization, it depends on the number of surgeries performed. So more than 10,000 surgeries, then the fee, annual fee is say 2,28,000 plus GST per year. So how do you go about it? You can go to their website and download the manual, which is seen here, or you can buy the manual online. It costs about 1,500 rupees, and then after that go through it. There are 10 chapters and there are objective elements. You have to fulfill those elements to get the marks. Once you've gone through that book, you identify your gap, do the gap analysis of your hospital, and then you fill in those gaps, and only then do the application. Then you pay the fee, and then you are given dates and names of the assessors, coordinate with them, and undergo the assessment. Of course, then you either then they give you a chance. They tell you what gaps they have found out, and then they give you a chance to kind of rectify those gaps. That is called NCs. And once you have covered those NCs, then you can be accredited. So there are 10 chapters. I think the speakers will be speaking on the elaborating these chapters, but just to rush through, the first chapter is access, assessment and continuity of care. That is from the time the patient walks in to the time of discharge and follow-up. Whatever has to be done comes under this chapter. Then there is a chapter on care of patients, which deals with the emergencies and the anesthesia guidelines. Then management of medication, how your prescription should be, who should be writing. I think the details will be discussed by this way. So I won't go into all this. And then there are some organization-centered standards. So these also have to be fulfilled. Now I just want to add, this is not yet there in the Ophthalm manual, but it will soon come, because this is there for the general hospitals who run multi-speciality. And so now they have divided the objective elements into core, commitment, achievement and excellence. They have categorized each element. And so the core means the basic. The commitment is something little more that we are going to fulfill. And achievement means over and above what is required. Like for example, if you have the latest technology, then you can mention that in your achievement elements. And excellence is what are your best practices. Like for example, if you have a program running on antibiotic stewardship, so that is your best practice in your hospital. So if you have a microbiologist, a pharmacist taking care of the antibiotic use, then you have fulfilled even the objectives which show that there is excellent patient care in your hospital. So I'll just skip these and There are various workshops that go on. You can get the details on their website, attend them, get accredited, and once you're accredited, you can start calling up your friends and putting it up on WhatsApp that finally you're there. Thank you.
Thank you, Dr. Mohana. Dr. Nirmal had a death in family, so he had to rush for ceremonies today, but we do have his talk, and I'll cover up your questions for that. So the important step is now we start the course. So why we want accreditation, and that's one point all of us have. And especially the question next we get is, I have a solo practice, do I need accreditation? And can I do accreditation? So the answer to that is yes, you can. In fact, I have met so many of my juniors, seniors, colleagues this conference who have got accreditation within the last physical AIOS and this, and they're single man practice. When you want to go is your comfort level. Basically, initially you are setting up your practice. The level where you are comfortable that, okay, my practice is set now and I can going for the next step would be the way to go. You can't start it from day one. Let your clinic run at least for 3 months, 4 months, get the data enough to apply. And city to city, there might be variation. In a metro, you might like to go in for an early. In a smaller city, you might like to go in for late. Also, a big factor is what is your percentage of insurance patient? What are you losing? So get empanelment. If you are losing 50% of a patient, then you would like to get it early. But if your insurance component is only 5-10%, you have a leeway to do that. So we'll go with the first talk, which highlights the benefit of accreditation. It's a generic talk, but the eye care standards or the aim of NABH and AIOS to develop eye care standard, that was in collaboration. So there were 5 people from AIOS and 5 members from NABH who sat together and make this standards. I was one part of it. Dr. Nirmal was secretary for that committee, and Dr. Sunita was also part of it. So the aim there was that standard should be
recording in progress.
No, it's a video. You need to turn on the audio. So standards should be taken care of all. It does. So don't get worried about certain requirements. They are specific to your practice. If it's a one-man practice, many of the standards, what they ask, requirements will be tuned to yours. No one is going to come to a small practice and ask you to show a standard as a big institute. Okay. You can't expect an LVP and Narayan Netral. Even if I get out of Narayan Netral in my practice, the standards are not going to be the same. So this is the first talk, and let's see if we can get the sound pro.
Good afternoon, SCD. I thank Dr. Gagan for this wonderful opportunity. I'm sorry I couldn't join you directly for this instruction course. I have to rush back to Chennai for an important meeting. So my topic today is on the benefits of accreditation, why it is needed for modern eye care practices. And these are my credentials. I've been with NABH and in the accreditation industry for more than a decade. I work with NABH as in a honorary capacity as the principal assessor and passionate to improve the quality of eye care services. So what are the benefits with reference to accreditation? So basically we have 3 group of practitioners among us, the fresh postgraduates who are just out of the medical college or fellowship, the young practitioners with minimal experience in managing hospitals or heading the departments, and then we have the third set of practitioners who have experience in running the hospital or managing the multiple chain of hospitals. So basically accreditation is self-assessment and external peer assessment process used by the hospital to accurately assess their level of performance. So this is important. The 3 key words are external peer assessment. Second is the performance in relation to the noted established standards, and then to implement ways to continuously improve it. So how do we do this? So it's based on written and published standards. The reviews are conducted by your own peers, and this process is administered by a third party, is an independent body. And aim of the accreditation is to encourage organizational development. As you all know, when you enter healthcare or those who are working in healthcare, we know that it's a very complex process involving various stakeholders, the government, the insurance companies, the staff who are working with us, the doctors, the staff nurses, the allied medical professional, the service providers like housekeeping personnel, drivers. So it's a maze of, it's a complex process. And what accreditation does is it simplifies to help us understand the system in a better way in terms of structure, process, outcome, and the input and output. So basically, it helps us to understand the various aspects of running a hospital in a simplified manner. So accreditation benefits a lot of, you can see a lot of logos in many of the brand centers in the brochures and the displays. So right from the JCI, which was one of the earliest accreditation, to NABH and then ISO. So how does this help? It helps us to understand the regulatory requirement of running a hospital. So the base of this pyramid is the regulation, law, and ethics. Most of us are not aware of this when we come out of medical college or even in private practice. So it helps us to, the standards helps us to understand the regulatory requirement of running a hospital. The second important aspect is documentation or process management. So we are happy with the clinical work, but unfortunately many of us don't understand the importance of documentation and its importance in improving the practice. So it helps in understanding the efficiency, improving the efficiency, and also understanding the process. And once we do this, we can keep on working at the documentation, and with efficient tools, we get enough data to know about the wastage in our practice, the defect, and also the ways to reduce or eliminate rework. So this actually takes us to the next level in patient care, that is excellence in patient care. Once we reach this step at pyramid, we can also see that there is a perceptible improvement in patient satisfaction, employee satisfaction, and management satisfaction. So with this background, what are the benefits of accreditation? So we are always used to seeing the benefits on differentiating medical care with reference to primary, secondary, and tertiary benefits, or you can also classify them into minor and major. So if you see most of the hospitals, once they get accreditation, they promote the hospital in a big way as moment of great honor. And so this is one of the important aspects of branding and marketing your practice. So the major benefit is to promote your practice, make it viable and sustainable. There is benefit for the management, and this is the best tool for doctor, entrepreneurs, and administrators who are new to patient hospital management. So this standards helps in improving the patient care in all aspects, right from the accessibility of the patient, the display of services, the care plan, the care of patients, the medication management, and of course infection control. It engages the staff. Most of us are finding it difficult to manage the staff and make them align with mission, vision, and objective of ourselves and our hospital. And accreditation standards really help the staff understand this mission, vision, objectives, and also improve their orientation to our policies. And the application of quality tools to improve management. So most of us are not aware of the management principles and the operations aspect. So standards help us to learn these operations aspect and also implement certain measures to improve them. This is the most important aspect of why people go for accreditation, because accreditation has been incentivized by these insurance companies by making it mandatory for empanelment with reference to ECHS, CGHS, Ayushman Bharat, or the PPN network. And they also incentivize by giving 10% more to NABH accredited hospitals. This is one of the important branding element, benchmarking our practice with reference to various quality awards and based on quality indicators. So most of the companies or organizations giving the healthcare awards is based on these indicators. Accreditation helps in scaling up our practice by offering a system of evaluation and empanelment to third parties like government, insurance companies, angel investors, medical tourism promoters, and same way it also gives the important information of our facilities, infrastructure, governance, and level of care to these funding agencies. There are a lot of benefits for hospital employees. The system measures employee satisfaction, improves employee safety and security, and there is a clear communication between the management and the staff once the accreditation standards are implemented. The most important beneficiary of accreditation are our patients. So they have access to a quality focused hospital. Their rights are respected. There is an understandable education and communication based on the accreditation principles. So their satisfaction is evaluated. They are involved in the care or decision making process. So overall, there is focus on patient safety and care. So is accreditation beneficial? Yes, over a period of time. So there is a time gap between the two cycles, that is 3 years, and over 2 years, 2 cycles or 3 cycles, the standards ensure better outcomes. It increases efficiency of the hospital. It enhances quality and safety, and most importantly, it reduces risk in terms of medico-legal challenges. So overall, accreditation standards is a win-win situation for patients, staff, management, government, and payers. Now I'll come to the second aspect.
So that was the first talk. I forgot to introduce you to Dr. Nirmal. Dr. Nirmal is currently president of IMA in Tambram. He is also incoming president for TNOA. He was the lead for developing eye care standards. One of the first assessors from ophthalmic fraternity. He became an assessor in 2008 when probably NABH started. So he has been on forefront, and all this, whatever we're following, he has been also at front of training. So we have had almost 40-45 workshops all across India with Dr. Nirmal leading that along with me. And probably you might have had one in your town or would have attended one. So with that, we'll go to my talk. So the thing is, now if you have decided to go in for NABH after this introduction, and if you feel that it's going to help you, how do you start?
Good afternoon, everybody.
So I work with Narayan Netralaya. I'm an assessor with NABH. Those are my affiliations and disclosure. No other financial disclosure there. And some important terms which we are going to use in presentation sometime, you'll find HCO, ECO, SHCO. So HCO is healthcare organization, means the hospital. SHCO is a small healthcare organization. Small here means less than 50 beds. And ECO is an eye care organization. So these reference definitions or these things you'll find all across our presentation. So just remember, ECO is an eye care organization. So when you want to go in for NABH, you'll heard all those things, ECO. So this is an eye care standard book. This is a hospital standard book which Dr. Mohana was talking about her in, keynote address. And this is a entry-level standard book. So first and foremost, when you're going for NABH, you have to select one of these standards which is applicable to your hospital. Eye care standard is applicable to any eye hospital, irrespective of size, but it should be only eye hospital. So if you have an eye dental, this will not be applicable. Or if you have an eye gynae or eye along with some other thing, this will not be applicable. In that case, you will have to go in for either an SSCO standard, okay, or if it's a huge hospital with eye care as part, then you'll have to go to full accreditation standard. But if it's a standalone eye hospital, use this standard. This is specific to eye care and helps a lot. Now, this is an accreditation standard. This is a pre-entry standard, which we talk about insurance. We say, no, you need pre-entry accreditation. Now, this is not an accreditation. It says pre-accreditation, but it's actually a certificate. So it's called a certification standard. So you get a certificate which is valid for 2 years, whereas in accreditation, you get an accreditation certificate, right? So that's the two difference, though the name is misleading there. So once you choose the standard, you need to get a copy of that standard. Which one, sir? This is 2 years. This is 3 years. We had that video, no, a cycle of 3 years. So all accreditation standard, this one, it's a 3-year cycle. Certification is only for 2 years. So 2 and 3, there's no other value to remove. So again, we had this. All these books, if you are going to see, which I showed, will have 10 chapters. It's standard. And these are the names of those chapters. So all of them will have 10 chapters. First 5 chapters are clinical chapters, patient-centric chapters. These are all organization-centered, basically management chapters. You can call in this way. So this is our clinical part. This is kind of management part. Okay. So this will be same across any standard you take. So it's very easy for us as an assessor and hospital to scale across standard. So what the difference will be in AAC, if you are starting with small standard, let's say there are inside only 3 standards and 15 elements. The more you go, the number will keep on increasing. Okay. So these are just comparison. iCare has got 305 standards, and FSCO, the green book which you had here, entry level. This one, it has got only 105. So now you can get the difference, how much it would be. So that's why you have to do less. This is 149, this is 305, so it's half. So that's why it's a stepping stone, and obviously it's easier to do in case you want to start. How are you going to get these standards? You have to go to NABH website. Now most of the information has changed on NABH website. Things have changed quite a lot during COVID and last 1 or 2 years. So for current information, if you have any doubt, dilemma, check on NABH website for announcements, for changes which come there. Even we are going to assess that, or we get a mail from NABH that this change has been done. So that's the way we also keep abreast. Don't go in for any hearsay. Anything which comes onto NABH website is the thing. So if you are going to go there, here in accreditation, you will have this one page where you can download this standard free of cost. Earlier it was not. So you can download PDF of all these standards free of cost. If you want a hard copy, you'll have to order with whatever money, and then they send it via courier to you. So whatever standards you want, so basically we need iCare standard. You might like to have this standard for reference, because this being the Bible, if you have a doubt, we refer to this. So this is our reference book, you can say. So our subject book is iCare standard. Reference book will be this in case you want to refer to something beyond, or you also have an iCare guidebook to refer to. So when you are going to NABH website, this will be the page, and you are going to go to the accreditation, and then you will get this iCare program. If you are going to go into iCare program, these are the things which you are going to get. It gives you quite a significant information what you need to do, which if I try to cover will take quite some time. So go through this, all these things. And your next question would be, what is the current fees? The fees is mentioned here. It is mentioned here. It's the bottom part of this. You scroll down, you get also the fees which is applicable. And here you have to see, there is no concept of bed. That's the difference in iCare standard. We don't count beds, because you may have a 2-bed organization, something. So instead of bed, we count the major surgeries, not the minor surgeries. So number of surgeries, what you're doing, based on that is your size of hospital, and accordingly you pay the fees, right? So that's the difference again, that ECO will be cheaper for a smaller hospital. Major, yeah, what else is there? Minor, I mean to say something which you are doing minor OT, chale is on by CK. You count your cataracts, you count your refractive surgeries, you count your retina surgeries and make the yeah. ठीक है, अभी रिवीजन है ना, मैडम ने बोला उस टाइम कन्विंस करा दो माइनर. Okay. चलो good, at least someone is listening. अच्छा, then you go there in resources section. Okay, all the new announcements are going to come here. They've changed the website recently. If you have accessed it earlier, go again. And in resources here, these two guidelines are very important. Guidelines for air conditioning. This is a Bible now. You follow this. And see, in case you are not complying to that, please check what leeway can be done or something. But beyond this is not what NABH is looking for. Okay. So one very clear thing in this guideline, when you read, it says no modular OT required. You want to have modular OT, your choice. But there is nothing like that, that for NABH you need to have a modular OT. Which again brings me an example, a practice in Rajasthan, flourishing practice, minting money, not an issue. They decide to go in for NABH. We want to be better in the city. And someone gives them a suggestion some 5-6 years back that you need to have a modular OT now. And it will take some 30 days or something. They closed their practice, OT was closed, modular OT took some 3 months, they can't operate, and they spent huge money. Modular OT also they bought at double the price according to me. And in the end, 3 months of OT closure, double the price, and they are going in for an entry-level standard. It was not required. So wherever in your hospital now, you get an advice or you read somewhere that a major reconstruction, major expenses involved, double check. See, you buy a mobile phone, you ask 10 people, yeah, which model is good? You buy a car, you ask 10 people, yours is going okay. So that time, for 20-30,000, we have our due diligence. Here, people suddenly spend lakhs and lakhs of it without even having a second thought. सर आप इसको डाउनलोड करके पढ़ लीजिए. तो ये है, इसमें कुछ भी डाउट है, all of us are available and all our talks are already, last AIS are on there, you can get our details if you want. Please mail us, please talk to us, whatever we can clarify we will.
Just one question, sir. So do we need HIPAA filter or AHU unit complete?
HEPA filters can't be installed without AHU. Air handling unit will have HEPA filter on the inside. I'll come to the OT designing. We have a talk on that. Okay. Then these all NABH brochures, and here you will get all the training programs also. This site is informative. You want to become an assessor? They have called for application now for becoming an assessor till 11th of June. So that is a new announcement there. Okay. Now this is the most important subject. Talk to your friends. Okay. And the most important caveat is talk to your friends outside ophthalmology. Because ophthalmology audit is cut and paste for me now. Every hospital is making the same mistake. Or let's say not a mistake, is missing the same thing. So 5 eye hospitals will have the same 5 sets that this was not there, this was not there. So I can just cut, copy, paste and give a report. Why that is happening is because in ophthalmology, some 80s and 90s, somewhere the mistake has happened in our big institutes, and that has been replicated everywhere. So, I have seen something wrong, I have copied something wrong. I have seen something wrong again, someone copies again from us. So, visit other specialties which are similar, like go to an ENT hospital, go to a general surgery hospital, which are going for a similar standard, like an entry level, and you'll get your answers. Asking answers amongst ophthalmologists is more of a time waste. You please go out and see. And next step is visit the hospitals. So, go to any NABH accredited hospital, this is ours, and see for yourself how that is appearing different from your hospital, how the things are being done different. You will get a broad mind how you are going to implement in your hospital. Because we have been working in healthcare, half a day, you will actually see what changes you want to make. And then you can make a list of it and, document and do that. So, people have done it, we can always learn from them. Especially now when so many hospitals are accredited. Initially it was difficult, the pioneers had a tough time because you only had to seek answers and ask NABH and ask other people. But now every city there is a hospital which is accredited. And if you are practicing, we'll do have friends. And again, there is a regional flavor to NABH as far as certain documents and certain things will concern. So that you go by your region. Your state will have some regulations. So what I am doing in Bangalore may not be applicable to you, the state regulation part. So be aware of those changes. And one very interesting anecdote here, 2 of my juniors, one my MBBS junior and one person who did fellowship in our hospital, finished, they had their practice. Their practice is about 1 kilometer apart. Both of them went in for NABH assessment, and that was also on same date coincidentally. Okay. Accreditation done, they got their report. 1 week later, both of them are sitting together in evening over a drink, and then they're discussing NABH. They had a disagreement and they called me. Okay, sir, both of us have this thing and our hospital are same, this is same, they have got NC, I have not got NC, this is, I said, what happened here, sir? Finally, I found out one of them had applied in eye care standards, the other person had applied in entry-level standards, and hence the report was different. Okay, and the guy who had applied in eye care actually wanted entry-level. Both of them wanted entry-level.
You need to apply for entry-level first.
Sir, no, you can apply for eye care. Aapka choice hai. You decide what you want. So that's why I'm saying, first decide what you want. See, now this guy has done everything and realizes that I wanted entry level, but I have applied for eye care. Why? Because some consultant said something or made mistake or whatever it was. Okay. Now, where will you get more information after you have these guidebooks and all? Attend training programs. We have done 45. We have been doing it. We're starting again. If your state society or district society wants us to conduct a training program, please invite us. We'll come. NABH does training program. Information comes onto NABH website. You get a certificate also for that. 1-day program, 2-day program, 3-day program. Program on implementation, POI they call, is a flagship program for NABH for any standards. And then there is something called CAHO. You can Google CAHO. CAHO does these training programs extensively all over. They also give you certificate. So AIOS and state society, these are the areas where I feel you get specific. The AIOS and our programs are totally geared towards eye care. We don't talk about anything else. Other programs are generic in nature. So if you're multi-specialty, those programs will be better. You can send your staff, and once the programs are happening in every nook and corner, the traveling is not an issue. Earlier, they were restricted to metros alone. In fact, in Maharashtra, we have had a program in Nashik, Pune, Mumbai, and Nagpur. 4 we have done pre-COVID. Aurangabad was due, I think, so that's the time when COVID started. Okay, so we lost somewhere. Okay, and this one book you can download. This is an AIOS CME series. Madam is an author, I have authored, Dr. Nimal. So whatever we know, we have actually compiled in this book. So our knowledge is there. You can download this from AIOS website and see if this helps you. And very important thing, it has got a good list of KPIs to be done, which is for ophthalmology, which will not get anywhere else. So then you can go into the entry-level certification. Here again from this certification section here, and here you will get one guidebook. You get assessor guide also, which we read and come. You will also get HIC manual which you can also adapt for ECO. You'll get sample SOPs also, which NABH has put. And there is accreditation. So these arrows, these 3-4 things you take from entry level, and you can get started. So you'll get the flavor of things, how they should be. Hand hygiene is one component. For hand hygiene, don't break your head. All of us follow WHO hand hygiene page. Go there, there is videos, how to do, everything is there. You can copy, it's a standard all across the world. Then WHO Safe Surgery Checklist, take this. It has been adapted and published in various state journals, various national journals. You can adapt also for eye surgeries, change it, nothing to be done. Use a standard format, no need to make your own checklist. Some things you want, add to this one. Important thing, high-risk drug list. ISMP high-risk drug list is a standard which we use. You can again see which of them you are using in your organization, and that becomes your high-risk drug list. Right, no need to copy paste. You copy from other hospital, half the drugs which we have are not there, half the drugs which they are using, we don't use. Then LASA medication. LASA is look-alike, sound-alike. Again, you can take ISMP list of confused drugs, and if you want to use this tall matter thing, this is again there, where we write them in a mix of small and big letters to avoid confusion. So these lists are also standard. Take this list as a base, and then you can add upon whatever extra you take. Okay. Then more information. If you want to go a step beyond and you really are serious beyond this insurance and other things, that really I want my hospital to stand out. One of the best way to start is look at all these other organizations. They put lots of information, and whatever we feel is going to help us, we adapt happily in our organization. So their pages will get so many things, checklists, tools, some case reports will be there, and then you can see how we can get that into our practice. So that will be a brief thing how we can start. And I next invite Dr. Sunita Dubey. She's going to take you through a difficult process of implementation. She has done for our hospital, she has done for many hospitals, and she is right now medical superintendent at Shroff Charity Eye Hospital, Daryaganj. Madam is also heading glaucoma unit there since I was a fellow. And she's a very good teacher, very humble human being, and always approachable. That's a good thing. So I really like people whom you can approach in case there's a problem. There are many people who are not approachable at all. So Madam is one. If you really need help, you also can approach her. Thank you. So Madam is going to talk about how we can have this knowledge and broadly the steps how we can implement in the hospital.
Okay, I would like to thank Gagan for giving me this opportunity to be in this IC, and I am going to deal with how to implement NABH standards and prepare for assessment. So I myself is not an assessor, but we had got accreditation in 2011. We were the first ones. So every 1.5 years we undergo the process of assessment and reassessment. So we have a fairly good knowledge about how to go about it. And if you have any problem, you can interrupt me in between. So this has already been covered. And NABH certification, as you were asking, that whether to go for entry-level accreditation. So yes, because it is easily achievable. If you have not yet gone for any kind of certification or accreditation, then this is a very easy thing to achieve, because it is cost effective also, and it is just 1/4 of the full accreditation standards. And Dr. Gagan has already talked about if you are more than 50 beds and more than 2 specialties, then also you can get the certification. But if you want accreditation, then you have to go in for HCO. SHCO if you are less than 50 beds and less than 2 subspecialties. So our hospital, Shroff Charities, ENT and eye, and less than 50 beds, so we have got SHCO. We can't apply for eye care accreditation. So differences, as you were asking, why it is easy, because some of the criteria, especially related to OT, the standards are less in entry level, and relaxation in OT criteria. As you were saying, in this particular, in entry level, you do not have to have AHU or HEPA filters. You can just do away with split ACs. So window ACs are not allowed, but split ACs are allowed. And then manpower requirement also, the nurse bed ratio and all are not that stringent. And the nurses requirement is less. You do not have to show the calibration. And indicators also, you can choose your own indicators and present. However, in full accreditation, the OT criteria is stringent, and then indicators also, they have a list of indicators. And of course, the fees is also different. So I think that is again a criteria if you just want to first go in for the lesser fee structure and prepare yourself well, go in for this accreditation, and you will be entitled for empanelment in CGSH ECHS, etc. So once you have started, selected the standards, it's a step-by-step process. So because, you cannot just achieve it because it is difficult process. So you have to first understand the standards. All the 10 chapters you have to understand. You have to have a team. I'm going to go in detail about all these things. So you have to purchase the guidebook or download it, and I'll just make you understand little bit about what these chapters are all about. The patient-centered chapters. So assess, assessment and continuity of care. So basically the intent of the chapter is that your care should be multidisciplinary in nature, provided by the competent staff, and encourages continuity of care. I think the last session they were talking about continuity of care. And you have to define everything. What is the scope of your services? And you have to not only define but display it also. So I think that is there are in asterisks there are some objective elements which are marked, which means that you have to document it properly, and some of them have to be displayed. And then you have to have good processes for processes for registration, discharge. You have to have standardization in your labs, diagnostics. So this is the intent of this particular chapter, which is a very big chapter. Then care of patient is another very big chapter. And the intent of this chapter is that you provide uniform and safe care to all patients in different settings. Suppose if you have a private setup and a community or a free setup, your standards of care should not differ, because assessors always ask, if you have, doing an applanation tonometry in your private setup and doing an NCT, or, not doing an applanation tonometer in your community or the free wing, that is not acceptable. So I think you have to have a same set of care or quality of care in both the setups. And then you have to have standardized processes for all your procedures, and like emergency procedures, your pediatric department, your anesthesia. You have to have a standardized plan of care for anesthesia, for sedation, for various processes. Management of medications, this is the third chapter, and we often neglect it because we are in an eye hospital and we do not use, too many medications. So this is a neglected chapter. However, you have to have a documented procedure for purchase, storage and prescription and dispensation of medication. He has already talked about LASA and high-risk medications, and you need to report and analyze your medication errors. That includes adverse drug reactions, adverse drug events, even adverse anesthesia events, because being eye hospital, you tend not to document these errors. Then patient rights and education. Patient rights, patients should be aware of their rights, and this is the question and by the assessor always. And there is interview of certain patients. If the patients are there in the hospital, both in OPD and operation theater, this is one of the important activity that the assessor is going to ask patients whether they were told about their disease, who is the doctor who is taking care, what is the prognosis, whether you were aware of the charges of the hospital. So all these points will be asked by the assessor to the patient. So I think you need to inform, you need to make the patient partner in their own care. So this aspect is very important. Hospital infection control is a very big chapter, and you need to have a comprehensive program for the or a manual wherein everything is documented, and you need to have a infection control nurse. You can designate anyone, and there are 3 days courses or 5 days or 7 days courses. They can undergo, even if somebody is not trained, they can undergo the training and get trained. And then you need to document high risk areas and how you're taking care of the sterilization, disinfection, what are the measures to prevent infections, and how you are going to investigate in terms of an outbreak or infection. Then, so these were the clinical chapters. Now coming to the non-clinical chapters. So continuous quality improvement, because NABH is a journey. It is not a one-time thing. So you have to have processes in place which will take care of the continuous quality improvement. So you have to have a documented CQI program in your hospital. And safety program, I am going to discuss about indicators and audits. And then the management responsibility is very important, because after all they are the leaders. So you have to have a proper organogram and a vision, mission and quality policy of the hospital. In facility management, you have to have a good plan for prevention and preventive and maintenance plan for the equipment and site layout, floor plans, fire escape routes. I think all these things are very important, and they are going to check. HR again is a very big chapter, and these are the things which need to be included in the HR manual: the training records, appraisal, grievances, credentialing, privileging, and development of the employees. And last but not the least is the information management system. So you need to have in detail about how you are going to handle your medical records and how is your IT system. So once you understand all these chapters, what all has to be done, and this you can do only by reading the book, guidebook in detail. So then you have to find the gap of your actual performance versus the desired performance, where you have to reach. And you should not rush through the process of gap assessment. When we did for our hospital, we did it, at least we devoted 1 week at least to find the gap, because we had to go through all the departments, clinical as well as non-clinical, right from the registration to the inpatient to, the operation theater, discharge process, and then HR, and all non-clinical aspects, facility, infrastructure. So you have to do it, and then there is a self-assessment toolkit which is available. And this is just one example which I would like to give. Suppose this is the first chapter, assess, assessment and continuity of care. So the first objective element is, standard is, the organization defines and displays the services that it provides. So what does it mean? That means the services which you are providing should be clearly defined. Suppose if I am just doing cataract and anterior segment, I am not doing retina or anything else, oculoplasty, then it should be defined. Not only defined, it has to be displayed at the prominent place, and that will be seen. So you have to display your scope of services at your main gate or door. And staff is oriented, because they can ask anyone, any staff, whether he or she is aware of the services in the hospital or not service. So I think this is one of the example. And
Even the services are provided by the visiting surgeons.
yeah, that is there. If you have visiting surgeons, then you have to mention what all you have been provided. And then initial, suppose patient cared by the organization undergo an initial. So what do you mean by initial assessment? In most of the eye care organizations, we assess the patient very fast, within 1 hour or 1.5 hours, as opposed to the multi-speciality hospital, where they may take a few hours, up to 24 hours. So in HCO standards it is written 24 hours, but in eye care standards you can define your own time, that we are going to assess within 2 hours, and optometrist is going to assess the patient first, or nurse is going to assess. So you have to define. So this way, this is a self-assessment tool for all the objective elements. You need to document whether you have documented, implemented, and what is the evidence. You have to show the evidence also, because whenever you are going to send your compliance report, you have to show the evidence. They are not just going to agree that you have implemented. Where is the evidence? And then you can score. So this is a self-assessment toolkit. So you score yourself, where do you stand? Out of 10, how much you got? Okay, so you may be having gap when you're thinking of applying or going in for accreditation. You may be lacking in terms of having all the licenses, MOUs, medical records in terms of completeness of records, retention policy, OT records. You may not be maintaining records for culture reports, temperature records, humidity, or in autoclave recall process, indicators, and how you are going to refer as if we do not have all the specialities, we should be having a process how to refer the patient. In infrastructure, you have to have a complete fire safety thing in place. You should have equipment. And you need to do mock drills in between. Okay, so training is a very important aspect because assessor is going to check the training records, and you have to give your staff members training for BLS, okay, basic life support training, fire safety training. They should know how to use a fire extinguisher, what to do if there is if the fire breaks out. Then SOP, whatever standard operating procedures you have to give training to your staff, your HIC practices, hospital infection control practices, how you are going to monitor indicators and all, and common hospital policies like hand hygiene policy. It has become all the more important during COVID times. Biomedical waste management and needle stick injury. Everyone should know how to do this. So NABH is all about documentation, implementation and evidences. So you can't work on your gut feeling. You have to have proper implementation and proper evidences that you have implemented that. And as I said, since all of us are very busy, all the doctors are very busy, if you can dedicate one person, it can be optometrist also, it can be nurse also. If you are a very small hospital, say, just one, the clinic or a very small hospital, then you need not have so many committees. You can have just one core committee who is taking care of everything, and it is better that you have an optom and a nurse part of that committee. So these are the 4 pillars of accreditation: documentation, HIC, safety and CQI. I have already talked about the SOPs and all, statutory requirements, licenses, and documentation. You need to have all these things, and in the guidebook you will understand what is a standard operating procedure, what are work instructions, what are manuals. So I think you will have to go through it. And common standard, you should have common standards. So you have to document the plan of care. Suppose if the patient is, I can take 5 minutes more? 5 minutes. Okay. So plan of care, suppose the patient is having glaucoma and cataract both, and you just want to do a cataract surgery. You have to document that patient right now, I have planned for cataract surgery. The patient will be, the glaucoma surgery will be done later, or patient has been advised to use medication for the time. So the plan of care has to be documented properly. Although I don't think that much of detail is checked, but I think for your own, care, if you make your care, a very standardized care, then I think you have to do. Then safety management or safety protocols are very important. Report medication errors, ADRs, near misses, sentinel events. In our case, sentinel events, that means can harm the patient permanently also. So in our scenario, these are the sentinel events: endophthalmitis, surgical site infections, number of surgeries in which wrong IOLs were implanted, although it is very, very rare. But still, number of surgeries where wrong eye got operated. So each of this investigation should trigger or each of these events should trigger an investigation. So just say you have to do and find out the cause, why this endophthalmitis has happened. Whether there was something wrong in the operation theater, or wrong in the viscoelastics or consumables, whether it was patient factor, uncontrolled diabetes, or surgeon factor. So I think that way you can just analyze the cause. And surgical, Dr. Gagan has already talked about this checklist which you have to apply before incision, before surgery, and before the patient leaves the operation theater. And these are the indicators which you need to monitor, and they are measured over a period of time to achieve improvement. So structural processes and outcome indicators. So structure indicators, you can, it indicates the availability of resources like equipment, infrastructure. And then process indicators like waiting time, time taken for initial assessment, hand hygiene compliance, and then we measure a lot of outcome indicators like patient satisfaction, surgical outcomes, adverse drug reactions, re-surgery, and resource utilization. So this, you can go through this chapter in the NABH book, wherein they have given a list of clinical regulatory indicators. So, and in that book which Dr. Gagan showed, we have this chapter of quality indicators for an ophthalmic center. So you can just, decide for yourself how many indicators you're going to monitor, whether 5 or 10. And in entry-level certification, you just have to monitor 5 indicators and send them across. And then audits. Finally, the audits. Audits basically it is to achieve improvement in documentation, and they are the integral part. So what we are interested, all 4 types of audits have to be done. But initially for certification, you have to do internal audit, which is the audits of the systems and processes, and medical record audit, which emphasizes timeliness, legibility, completeness of case records. And medical audit, this is a peer review of clinical care of patients provided by the clinician. And as you understand the parameters more and more, then you can go in for clinical audit. Although 1 or 2 clinical audits are essential for accreditation. For entry level, I think clinical audit is not important. So medical audit, you have to see whether all the examination points, whether your history, your documentation of management plan, your diagnosis, everything is done appropriately. And if not done appropriately, then you can score yourself and try to improve over a period of time. And this is the internal audit to check compliance with the processes. So finally, what the assessor will check: facility round report, committee documents, clinical audit reports, statutory and regulatory compliances, HIC surveillance activities, personal files, that should include registration, appraisal, grievances, antecedent verification, training records. And these are the CQI, which I just talked about. So I think this all you need to keep ready. Okay, so whosoever is the head of the institute, even if you do not have time, you have to take keen interest, because without the involvement of leadership, this accreditation process will not be possible. And then patient safety should be your diktat, and encourage incident reporting without penalizing. People should not be scared that if they report incident or any untoward event, then they will be penalized. That should not be there. Measure and monitor quality, as we discussed, with indicators and audits, and develop an information system. Continuous training is very, very important. So this is a very lengthy process, but you have to get into it.
So this actually is a 6 hours content, which Madam has brought down to 20 minutes. It's a heavy presentation, difficult one. But the problem here is to bring it to 20 minutes. Ma'am, we'll take all questions. Let's have an important, now we'll take break.
Yeah.
So we'll go to OT. Because I think so bulk of the questions are going to come to OT already asked. We'll have the OT presentation, then we can have questions. Or we'll quickly wrap up. We have time because we took keynote first. So we have time till 1:35. So we have time on that. Yeah.
1:25.
So quickly I'll go to the OT talk. All of us
Recording in progress.
OT talks. Dr. Nirmal has, my OT talk is also there. But since he is the senior most, we thought we'll use his talk there. So let us see on the OT part, and then we quickly wrap up another few things and go into a discussion mode.
So planning and designing a safe and optimal OT. So this is the most important aspect in running a healthcare facility. So how to redesign or design my OT according to NABH guidelines? This is one of the frequently asked questions in many accreditation related meetings. And how do we ensure structure, process, and good outcomes in my OT? So, are there any NABH guidelines? What are the standards and what are the references? So, to answer this it will take a long time, but I'll just give you a brief note on what are the references. So, very often people tend to ask about references. So, the Indian standards, there is a part 1 to part 3, and various ISO standards give certain references. And IPHS norms for Indian healthcare facility was recently amended to include the infection control requirement also. And then the National Building Code or NBC norms for hospitals. So this is a 180-page document which focuses on fire zones, the type of construction, the general requirement, both for smaller hospital as well as high-rise building. An important aspect of NBC is the focus on heating, ventilation and air conditioning in the operation theatres and hospitals, and the guidance note issued by ASHRAE or the Indian counterpart ISHRAE, Indian Society for Heating, Refrigerating and Air Conditioning Engineers, who given their guidelines based on Environment Protection Act and National Ambient Air Quality Monitoring Series. The next important regulation or reference is the Clinical Establishment Act, which governs the licensing of healthcare facilities. So it has given norms for the space requirement for OT as well as minor OTs for minor procedures, and it also given various zoning requirement. For eye hospitals, only where procedures are done in local or regional anesthesia, minor OT criteria may be applicable. So what is the minimum requirement for a procedure room? Minimum requirement is 160 square feet. That includes the space requirement for anesthesia machine and a crash cart. NABH guidelines were formulated by quality experts, manufacturers, engineers and technical committee members, and these guidelines have been finalized to include two types of operation theatres. One is the super specialty OT, another one is the general OT. So ophthalmology theatres would come under the general OT. This includes the daycare centers where patients return on the same day. So for OT standard, the basic assumption have been kept in view that for each surgery patients, there will be 5 to 8 surgical team at any given point of time, and the equipment used to provide care would be around 5 to 7 kilowatts. And ambient temperature and humidity at each location to be considered while designing the system based on the space. The third regulatory requirement is the NABH standards. So there are two important chapters which focus on infection control and facility management and safety. Even though there are 8 other chapters, for OT designing, these 2 chapters are the major references. So the intent of NABH standards is to provide a safe and secure environment for patients, their families and visitors, comply with the relevant rules and regulations and plan for emergencies. As you all know, infection control is an important parameter in hospital, particularly eye hospital. But infection control is a complex mixture of engineering, particle physics, microbiology and medicine. So we understood this during the COVID time. So how the size, shape, density and of course air movement plays a major role in control of infections. So basically, IoT is only the critical area in eye center. So you have to focus on structure, infrastructure and superstructure, the process requirement and the outcomes. So as a hospital leader, you have to think like a patient. If I am lying on this operating table, what do I want? So how safe the infrastructure should be there and equipment, or we focus on the lowest price or substandard structure above me. So this would be the defining question to focus on the short-term goals and long-term goals, the location and building design. Ideally, the operation theatre should be located outside the regular patient OPD areas, should also focus on the short-term and long-term goals and requirements. You have to focus on the equipment management and staff training, as well as patient safety and infection control. All these parameters have to be taken into consideration before designing an operation theatre. So planning and designing a safe and optimal OT starts with a two-dimensional plan, the equipment required, the power outlet backup, the lighting required, the mental picture of surgery being carried out, and a three-dimensional view of the OT, review and revise the plan. So step one is write down the scope of services, the equipment needed, and the space requirement for your dream OT. The space requirements are given for the regular hospitals as well as day surgery units in the guidelines given by IPHSA. The engineering service requirements are also part of the ISHRE guidelines as well as the National Building Code. You have to focus on the air conditioning, ventilation, lighting, data and voice points, CCTV and MATV outlets, as well as the transportation requirements. So the layout generally should follow the unidirectional flow of men, material and access from one side. So there should not be mixing of sterile and unsterile product as well as areas. So ideally, an operation theatre complex should consist of 4 zones. The outer zone for receiving the patients, the restricted zone or clean zone for changing room, stores room and anesthetist room. The aseptic zone where the procedure is done, as well as area for instrument packing and sterilization. And then the disposal area where the used equipments are cleaned and biohazardous waste is disposed. So this is a 4 well-defined zones that makes our life easier while doing procedures. And you have to integrate the OP and OT for seamless patient flow. So along with the ward, as well as if you are running a daycare facility, how the patient will come from the OP or diagnostic areas to the operation unit. So basically you need to consider the design and structure as well as the equipment, and maintenance of OT should be taken into consideration while designing the operation theatre. So form follows function. And you also need to focus on the OT walls. It should be dust proof or moisture proof. The corner should be coated to prevent dust and facilitate cleaning. The door should be 2 deep with self-closing device. You should have facility for natural lighting and floor lighting for retina OT. The scrub up and sterilization areas have to be properly integrated into the design. You need to have a disinfection area where there is a hand wash facility as well as discharge table for soiled linen as well as instrument, and also need to have clean storage shelf to store the sterilized product. Ideally, there should be wall hung items to improve floor cleaning. The important aspect of infection control is the role of engineering controls. So the PPE is the least effective and most costly, whereas elimination and engineering control are most effective and least costly. So how do we incorporate engineering control, and why should we incorporate? Basically, the air is used as a disinfection as well as dilution media by effective usage of ventilation. So you are diluting the infection control. You are improving the air quality by filtration. You are reducing the exposure time for infection by having a pressure differential or positive pressure. By using optimum temperature and humidity, you are also reducing the growth of microbial flora inside the operation theatre. So by adding ultraviolet treatment to the HVAC, you are reducing the viability of organism. Particularly this proved well during the COVID time where UV usage was rampant. And also airflow pattern. If you have a laminar airflow pattern, all the microbial agents are pushed out of the surface or the surgical areas. So this really helps in reducing the infection risk in the operation theatres. Ideally, operation theatre has to be a RCC control or construction or steel or modular build. And the AHU has to be dedicated one. It should not be linked to the air conditioning of other areas. And generally window and split AC should not be used any type of OT because it is only a recirculation unit, and there can be convenient pockets for microbial growth which cannot be sealed. The ventilation requirement, there has to be continuous air purifying if you are having a AHU unit. The temperature, ideal temperature in operation theatre is 20 to 23. Relative humidity is 30 to 60 or 55 plus or minus 5. Air movements has to be from clean to less clean areas, and air changes has to happen minimum 15 total air changes per hour. So basically, operation theatre design requirements are a legal requirement. Accreditation and empanelment standard require that theatre are properly built and designed. It helps in reducing the medical and surgical errors, and well-designed theatre is essential for better infection control. It offers a safe and comfortable area for all of us, patients, doctors, and staff. Over the long period, the maintenance becomes easy and cheap if it's a well-designed theatre, and it also saves us from medical legal cases. So a well-designed planned OT is important to get good outcomes in our eye care facilities. Thank you so much for your kind attention.
So I hope this one would have given some answers. All the references were mentioned from where these standards are coming, and maybe has raised few more questions. So another 5-7 minutes and we throw the hall open for questions. So now after this, if you are going for assessment, all of us get a call that tomorrow is my assessment day after, what should I do? Madam, if you remember, it was a long presentation. In the end, she mentioned certain things that assessors will look for. So those are mandatory things. So if you keep things ready, it's easy. So that, yeah, I think so this one. So we'll have a small video.
Good afternoon, everybody. I'm very glad to be amongst you today. I'm sure that you must have heard some very eminent speakers guiding you about the process of NABH. And I'm very thankful to Dr. Gagan Dudeja for giving me this opportunity. I am Dr. Samina Zamindar from Zamindar's Microsurgical Eye Center, Bangalore. I'm an NABH assessor, and I'm very, very honored to be a part of this All India Ophthalmic Society conference, though I'm not present amongst you. So today I'm going to talk to you about how to ace on the assessment day. I have divided my talk into 4 parts. The first part is prior to audit. What is something what you need to do with your team? You need to have a meeting with your team and tell them that this is a fact-finding exercise and not a fault-finding mission. So they need to relax, calm down, and look at the assessor as an expert who is going to come, travel from far away, spend the entire day with you, and teach you some important things to improve the quality and safety at your hospital. After this is done, you should also ensure that the emails what the assessor have written to you have to be read carefully, because there are a lot of points which the assessor would have written and asked for you in the email. One of them is details of what should be a part of the opening presentation. Now this opening presentation has to be submitted to you in a pen drive to the assessor to NABH. So please go through that correctly. There might be some other requests also from the assessor, like what were the non-compliances of the previous assessment. Please go through that. Something like the scope of services, the staff matrix, etc. So please read the mails and follow the mail instructions given in the mail. Prior to the audit day, there is one more information you should collect from the assessor. Is there what is their food preferences and if they have any food allergies. That would be really nice. This attention to detail is important here. You should also arrange for a room with privacy for the assessor or assessors to work. The second portion of my talk involves the day before the audit. The day before the audit, you should see that all the staff are requested to be present for the opening meeting as much as possible on time and in their proper uniforms. The hospital should be clean, neat and shining as usual. Moreover, there should be good Wi-Fi connection available so that at the last minute you're not struggling for the opening presentation or for the assessor's submission work. Now we come to the A part where what should be done when the assessor arrives at your doorstep. The first thing is to greet them and welcome them into your organization. Please do not worry about any bouquets or garlands or gifts. It's not required. The opening presentation should ideally be attended by all the core members of the team, core doctors, staff, very nicely dressed in their proper uniforms, and be present in the decorum of the meeting should be maintained. On the day of the audit, see that the assessor is accompanied by a knowledgeable staff, preferably somebody from your quality team who has good communication skills. And whenever you take the assessor to any station, the requisite registers and standard operating procedures should be available at that particular station. Whenever the assessor wants to interview a staff or a patient, requisite privacy should be given, and if you are allowing the assessor in any patient care areas where patient is present, you should take the consent of the patient for the assessor to be present there. Operation theatre is a key area of functioning of an eye hospital, and the assessor would like to visit the operation theatre and see it functioning. So please see that the operation theatre is functional on the day of the assessment. You should have posted some surgeries on that day also. An important area of mistake which most of us do is that we try to hide facts at times. Please do not hide facts. Be very honest and share all details, whatever are required for the assessor to know, very openly. Even if there are any legal matters which your hospital is going through, please share that with the assessor. Sooner or later, the assessor will come to know about it. The best thing is to share these details with the assessor. Few important reminders. No external person from any consulting agency should be present as part of the team. Be ready for any announcement of codes from assessor. Your rapid response teams for every code should be alerted. Note down all observations of the assessor as your quality improvement points. So the person who is accompanying the assessor should note down all these observations. And remember that assessment is a sampling exercise. So the non-compliances with this assessor has picked up, maybe they were not picked up in the past, but there is no point arguing with the assessor about it. I wish you all the very best for your assessment journey, and I hope that my talk was helpful. This is warm.
So another 3 minutes, I'll just cut short this post-assessment presentation to 3 minutes, and you can, in the meantime, prepare your questions. As long as they allow us to take questions, we are free for you. So post-assessment, what you basically get are lots of things, but the important thing is immediately you get something which is your non-conformances, right? So this is actually something like this will be given to every hospital, okay? So here there are 3 components. This is the standard against which the things were not found up to the mark or the non-conformance to that particular standard. That's why I say NC. So ROM 2G, Madam showed no, so you have to go to chapter ROM standard number 2 element number G. So like that it will be very specific that the functioning of committees is not reviewed by the ECO for their effectiveness, okay? Now what you have to do is you have to make sure that you do that review, and that review will be in form of a document, in form of a structural change, whatever photo, PDF, and that has to be uploaded here saying that what changes you have done. You can say that we had a review meeting for management and this thing, and this is uploaded. Now another thing is we were also saying that the person who's accompanying the assessor should take note. So it's a sampling exercise. Though the NC is generic, here it does not reflect which committees were picked for sample, and the functioning was not there. It would be 3, 4, 5. And then after 5 they said, okay, anyways you are not having more than 2, 3, 5, so it becomes an NC. So there you can actually check with your notes that what was the committee minutes shown. Maybe you showed the wrong minutes. Go back, do and close it. So here the closure is based on the evidence which you are going to upload. If you are not uploading that evidence, the closure will not be accepted, and you again get that submit closure again. Okay. So these NCs will be very specific. Like here, it says that there is no committee. So you have to make a committee, have an order that committee has been made, what are your members of that committee, have some minutes of your meeting, and then you upload those things. You get 3 months time for closing this thing. So mostly hospital upload something whereby you don't know what is the closure, whether it's a deliberate thing or they really have not understood. I still fail to understand. So NC is about medical record and upload is something else. Some SOP manual will come. Whereas the NC is reading that in medical record this was a deficiency, you get an SOP manual uploaded. So where that lacuna is, I don't know, but This is very specific, and in case there is a doubt, most of the time you can check with assessor that, what was the thing, I am not clear. They will again clarify in case writing wise it's not clear. So you can actually clarify what exactly it means in case there is a doubt. Let us give benefit, English is not our mother tongue. So sometimes, we make mistakes in probably communicating, which should not happen. Still a doubt, clarify. So this has to be done on time, and this is the basis where your assessment will get closed, and you will be put up for, case will be put up for accreditation committee to final accreditation. This does not give you accreditation. After this, each and every hospital case will go in front of accreditation committee, which will take a final call. Okay, so this anyways I have told you. So what will happen is, once this closure is accepted for AC meeting, you will get a mail from NABH and they'll ask certain things in a particular format. You would have already given those things, you have to give it again in whatever format they want. Typically manpower detail, a PowerPoint about hospital, some agreement, and certain other things will come. This is because this PowerPoint will be presented before AC. And then when they want further details, your old data will be referred to. Okay. And what we'll do after you get the certificate, first, after 2 years, you have to recertify. In case of accreditation, you'll have a surveillance assessment. After 3 years, you have to go for a reassessment. And continuity is important. These are the things which are on continual basis. These have to continue. It's not that we do it, get our accreditation, and then we leave them. Or the person who was doing leaves and no one else overtakes those things. So all those things, please take care that if you get NABH, please maintain these activities and make sure the NCs which were there in the first meeting are actually closed, and make sure that closure is there after 3 months or 6 months, because they were the weak areas for us. So any chapter where we are not good at, we see that we read it properly again. And most important, NABH has a timeline. So you have to reapply for your next level 6 months before it expires. Please apply 6 months before. In case you are not getting an answer, please be in touch with them, because in COVID that was not happening. So they would say, okay, we are extending for 3 months because of COVID. So you get, but from our thing, the date of certificate, whatever it is, 6 months before, please apply for this thing, and you can also write a mail to NABH and be in touch with them to make sure that it's done. Otherwise, if it's too late, there's a discontinuity certificate, we only suffer more. Right? Assessment is done 1 month before, the certificate will not come in time, and you are already using that for your empanelments. So this is in brief, though it was a detailed presentation. For questions, because madam wanted and everyone, please ask. So, madam, Mike, I can't hear you.
We wanted to do the NABH accreditation early, first level. So we are following the good practices since 2 years, and we have appointed some person from Mumbai. He has guided us all, and but I want to ask you one thing. We all of you, we use IELMaster 7 and everything. We have do we require AMC of every machine to be shown to NABH personnel, or what? We want to know.
Okay. So my take on that, and madam can add, first decide what are your critical machines. Okay, any machine which is critical to patient care, you should have an AMC. Okay.
Means I'm asking about Varion, IELMaster 700, OCTs
Madam, I am answering very generically. What are the machines which are critical for your operations? So a phaco machine, you should have an AMC, because if it's not running, your surgery will get compromised. Okay. So whatever critical equipment you have, you divide your, all your list. Now you have your anesthesia machine, multi-para monitors, they are all critical. So there you should have an AMC. Even otherwise without NABH, that's my opinion, and that's what I look for as an assessor. Now there would be certain non-critical machine, slit lamps and your indirects. There are multiple slit lamps in a hospital. If it's only one slit lamp, then it becomes critical. But mostly, at least in our hospital, like we have 25. I don't know how many you have. You may have 4 or 5. So those things then don't become critical. So those could be just on a regular annual check for functioning, and there need not be a comprehensive maintenance. Okay, some sort of AMC will be there. No, your biomedical engineer, someone will come and service. So let's say there are 2 words, AMC, CMC. Let us not mix. So AMC, CMC will conclude that where you are having a CMC or AMC on regular basis. Here you can have your service history. A slit lamp can be serviced and can be used. There is no harm. It's not a critical equipment, and it does not harm a patient, unlike a phaco machine. Okay. And certain old machines, you will not get CMC. They could be on a service basis. And certain machines like laser, you will need a certificate that they are fit for human use, especially laser machine. So how your vendor is giving that certificate is also important. He may give you on a service basis, or he will say, no, without AMC, I am not giving. Particular multinationals will not give without AMC. So you have to look in those cases. But the key thing, remember, if it's a critical equipment, we want it to be in a perfect shape to be used on a patient.
What about the equipments like OCT, HFA, these kind?
Sir, again,
Consider them in
again, if you have anything multiple, like you have IELMaster scan, I would not consider it to be critical. Okay, but if you have only one A scan and everything based on that, I would definitely see how you are calibrating and whether it's being serviced based on the usual requirement for that particular machine. So most of the machine, if you see, have a manufacturer guideline. Like if you take a car, it says no, service at 5,000 kilometer or 1 year. That's the manufacturer guideline. Now, if you don't follow that, what happens? They don't give you a warranty or your claims are not there. Similarly, each equipment comes with certain thing. You go with a manufacturer. So if they say this service laser has to be serviced 6 months, it has to be serviced 6 months. There is no alternative to that.
How about from third-party biomedical engineers?
No issues as long as they have kind of a certification or something, it works. No issues.
They have a certification.
Yeah, you can't just make an electrician a biomedical engineer, no? So if a firm is registered, it's a proper firm and all, it's okay.
So who has underwent a proper
That's okay with,
Yeah.
yeah, anything will work there.
So there are trainings available at Arvind and all.
Yes.
So they need not be engineers, they can be technicians who can be trained. And
ITI
on day to
technicians
day,
and
yeah,
all,
yeah.
they can be trained. So for your routine activities, but specific activities, if there is a trained center which has already done, no one is really fussy about that. See, what we are looking at is patient safety. That's all.
Here the complete concept is, madam, whatever she everybody is, the moment the word NABH comes, everybody is scared. So
that's why we are saying
that
don't be
should
scared.
go.
We are
That,
trying
see,
to
I
make
think
it
her
as
question
simple.
is that. See, she's having all practices. That's the only thing. Here, if you are okay with this biomedical engineer from a certificated person, that is a very beautiful thing. No, that is what that clarity she wanted.
So one more question. We have opted for the means everything is computerized. So do we need to show the OPD papers physically, or we are using OPD papers also and we have the
Madam,
computerized
EMR,
it?
as per the new Digital Act, if it confirms to that and you're following the provision, is accepted, you can have a paperless hospital.
Okay.
Now, again, okay, indoor becomes a gray area in terms of your consent. So, those gray areas, consent and OT notes, become a gray area where still you may like to have a physical copy kept. So you will finish the surgery what you are having and cancel off your list, and then you can do it in an alternate. No, you have to finish that case. अगर patient surgery start नहीं किया है तो वहीं पे close कर दो ना यार. If you are already doing surgery in midway, you will have to finish the surgery. If you put a split AC along with HEPA, it doesn't work. That will remain a pocket of infection. Your infection control will go for a toss. No, not an emergency. The very fact that you have split AC, you will not be able to have a clean chamber. You can't maintain that split AC in presence of HEPA filter.
Can we put glass for lightning in OT?
Yes.
Some people say it should not have any joints. So
Glass is sealed. World-class OTs abroad also will have glass which are sealed. Not an issue with that.
anything you recommend for paint and OT or some vinyl there should be?
OT guidelines from NABH mentions paint and vinyl. Please download. I gave you the link. It's clearly mentioned there.
Sir,
Please quote that to anyone you want.
One more practical question, sir. For refrigeration use,
Sir, split AC, if it's inside, you will not be able to maintain that, and you have an additional thing where the bacteria will harbor. Your AHU work will also not happen. So the whole purpose is we are using AHU for better control.
Sir, what he's trying to tell is, in the presence of AHU, again you are having a split AC itself is wrong.
Yes, because you will not be able to maintain. That's what I'm saying. No. And again, opening, how will you maintain that?
Yes.
What we told split AC.
AHU, inside you cannot have a split AC, sir.
सर बहुत सारे हॉस्पिटल्स हैं जहाँ पर दोनों हैं, आपने देखा होगा, ठीक है, बट अभी क्या बोला, जैसे जैसे ऑडिट अगेन होगा ना, तो those things get changed. So there are some places उनके पास NABH certificate भी शायद होगा where you would have found split. They have been instructed to stick to a proper AHU system with this thing. So that thing will not be there in coming years. That's all I can say. As and when they get reassessed.
Sir, for storage in OT, can we put some almirah or that is also not?
We have talked about zoning. जो आपका main OT है, there you have to maintain clean walls and clean floor. When you put almirah, it is difficult to maintain. So you can have a separate store zone, no? Sir, from one room to other, it is doable. We have 7 OT complex and all the things are stored in the OT store. Same for madam, 5 OTs or 6 OTs. That time, 8 OTs now, time has never been an issue.
Yeah, but we have kept small cupboards there.
नहीं sir, रखिए. No one is saying so. What happens is, like there are alternatives. आपको क्या करना? Yeah. No, big trolley also, which can be moved out for cleaning. So, see, we have to understand what problem we are facing and what is the solution. So, putting a fixed cupboard inside will create a problem in cleaning, especially when you have HEPA filters. Yeah, clip it, you can take them out for cleaning and you can clean the trolleys. Steel trolleys are easily cleanable. Anyways, we will have a...
Nowadays are available with wheels.
Yeah.
You can just, I think, clean.
So, everything, at the end of the day,
Yes,
you can
yes.
actually empty out the entire OT and clean if you want to.
Sir, what about this autoclaves? Do we really need horizontal one or vertical is
Okay, I'll give a cryptic answer. Any autoclave for which you can give me a certificate that it is fit for human surgery is accepted. नहीं, कोई भी autoclave का आप एक certificate manufacturer देगा कि if this is fit for surgeries in humans
See,
or fit for
it
surgery.
was because when we
I'll
underwent.
answer. मैं पहले certificate दे दो आप, जोन सा भी autoclave है accepted है. Now coming to the second part. जो vertical autoclaves हैं, उसमें वो certificate आपको नहीं देगा.
नहीं देगा.
वर्टिकल ऑटोक्लेव में कुछ मॉडल्स हैं जिसमें वैक्यूम सिस्टम है, वहां पर आपको मिल जाएगा. तो उसमें हमें सोल्यूशन क्या है? आपको अगर किसी मैन्युफैक्चर में कहीं डाउट है ना, उसको बोलो इसका सर्टिफिकेट है क्या, ये मैं ह्यूमन
Free vacuum, actually they ask for Bobidix test and all. So that is not possible in horizontal actually. That is in vertical, sorry.
नहीं, वर्टिकल में है, सिर्फ सिलेक्टेड मॉडल है, बहुत मुश्किल है ढूंढना.
बहुत ही selective
बट अगर आपको
models
मिल रहा है
हैं.
सर्टिफिकेट वर्टिकल में ह्यूमन यूज का एंड इट विल पास ऑल द टेस्ट, एक्सेप्टेबल, नो इश्यूज.
What about this pillars and OT? Sometimes like my OT has a height of 9.5 OT. Then I have to put a HO also. It goes down to 1.1. The effective height is only 7.
नहीं, पतले वाला, देयर इज अ थिनर वन अवेलेबल नाउ, 1.5 में आ गया है. सो 9.5 1.5 विल लेफ्ट विद 8.
Create some beams like that will turn like this and go and again stuck.
That I have not seen an OT, can't comment, but पतला जो 1.5 feet वाला भी अभी HU solution available है.
Is it not necessary to keep the whole ceiling in a one way?
Without seeing OT, I can't comment, and the person who's buying, from where you are consulting, they will tell how their system works. So that's a pure technical thing. Based on your OT, someone can guide you on. दिखाओ मुझे, मैं बताता हूँ ना यार, अब मैं verbally नहीं बता सकता what beam you are talking about.
Just a beam is coming and duct cannot pass. Duct has to go behind that beam.
अगर 7 feet पे तो आप ऑपरेट कर नहीं पाओगे. अगर जो भी आप कर रहे हो, if you are ending up with 8 feet, I think so you will get it.
That particular point, like some around corners of the OT, 3-4 feet is down, 7 feet rest, and the OT is like.
Should be okay the way you describe, but I'm not 100% sure of it. Sounds okay to me. Yeah, sounds okay to me. Without seeing, very difficult. But जितना आप बता रहे हो, it should be doable.
Comment on that circulatory system. That once the patient entry gate is separate or exit gate is also should be separate.
अच्छा, अभी मैंने आपको एक ना बिगनिंग में कमेंट दिया था, लुक आउटसाइड आई हॉस्पिटल. तो अगर आप अभी किसी अपने दोस्त के ओटी में गए हैं, किसी और स्पेशलिटी में, कितने डोर्स थे? अदर हॉस्पिटल ऑल्सो? ओके, आप एक बार फिर से देखो NABH accredited कोई ठीक सा हॉस्पिटल, जितने बड़े ओटी रहेंगे जहाँ पर यू रनिंग अदर. अरे नहीं यार, ओटी का, ओटी में 2 डोर मिलेंगे आपको, ठीक है. स्टैंडर्ड ओटी डिजाइन इज 2 डोर्स. आप एक ओटी डिजाइन का डालो ना, बुक खोलो, इतना हॉस्पिटल कंस्ट्रक्शन का बुक है, डाउनलोड करो या गूगल करो, हाउ टू कंस्ट्रक्ट एन ओटी, हाउ टू कंस्ट्रक्ट एन हॉस्पिटल. ऑफ्थैल छोड़ दो, उसमें आई मत डालना. यू सी मोस्ट ऑफ द ओटीज विल हैव 2 लीफ डोर, all those things which are talking, and they will probably also have 2 door depending on the outer corridor design. तो थोड़ा सा डिजाइनिंग इशू है. ऑफ्थैल में कहीं से भी शुरू करते हैं, वो एक ही है, मैंने भी बचपन से एक ही देखा है. So that same thing, 1 door and no light. That is a flaw which all of us have seen. Now to do that, what you can do, since our equipment, our instruments and all are small, you can put in a pass box. That's what all of us are doing in OT when there is only 1 door. So your pass box become a second sterile entry. But if you are constructing a new OT, and if you can get a 2 door, and if you can make a proper system, okay. पुराने OT में नहीं कर सकते, we'll have to find a way out. So the only way out to a second door will be to instead get a pass box, which can be retrofitted in most of the OTs.
What is the normal protocol? The assessor is from the same specialty or some other specialty?
Sir, eye care, we try that one of the assessors should be someone from eye background. It could be there, but it is not 100% possible. In some cases, especially after COVID, when traveling and availability become an issue, you could have a team which is not related, but they'll be NABH assessor. But if you are applying for eye care standard, typically it's an endeavor that one ophthalmologist should be part of the team. If you are going for small care and all, it will not be done. Anyone can come.
How many persons usually come?
Again, size of hospital, sir. Small hospital, 2 people will come. Big one, 3 will go.
Because I know one person, is a junior colleague of mine, he got NABH certified. So no assessor करके.
सर वर्चुअल असेसमेंट हुआ है कोविड के टाइम पे, तो बिकॉज देयर वर सो मेनी एप्लीकेशंस इन कोविड, देयर वाज एन हाइब्रिड असेसमेंट, देयर वर वर्चुअल असेसमेंट्स, बट अभी तो इट्स बैक टू फिजिकल असेसमेंट. अभी कल की रिपोर्ट से फिर केसेस, वी डोंट नो वेदर इट गोज वर्चुअल. तो वो थोड़ा सा ना 2 साल में अप्स एंड डाउन इतना हो रहा है, नन ऑफ अस आर एबल टू प्रिडिक्ट. हमारा भी असेसमेंट में प्रॉब्लम हुआ था. वी एक्चुअली वेंट इन फॉर अ वर्चुअल असेसमेंट एंड लास्ट मोमेंट ट्रैवल ओपन, देन वी हैड अ फिजिकल असेसमेंट. इन वन आवर अदर ब्रांच इट वाज फिजिकल, गॉट कन्वर्टेड टू वर्चुअल. सो वो हो रहा है. नो, जैसा चल रहा है, गो विद द फ्लो.
There are certain agencies in different cities that they claim that we will look after everything, वो आपको करा देंगे, ये कर देंगे. तो whether वो
सर थोड़े थोड़े मैं फनी एग्जांपल देता हूँ जस्ट टू मेक माय पॉइंट. हर बस स्टैंड एंड रेलवे स्टेशन पे इंडिया में, इवन यहाँ पर भी जब आप बाहर निकलते हैं ना, बहुत सारे क्लेम्स होते हैं. ठीक है, दे ट्रीट एवरीथिंग, मेडिकल क्लेम्स होते हैं, राइट? तो उसमें क्या है, वी यूज आवर ब्रेन, इज इट पॉसिबल और नॉट. तो सिंपल सी बात है, इफ एनीथिंग इज टू गुड टू बी ट्रू, इट इज नॉट ट्रू. और अपने को अपना लगाना है. अगर आपको कोई ऐसी एजेंसी बोल रही है गारंटी से, पहली बात तो दे नहीं सकते, बट आप उसका कोई भी एजेंसी हम पूछेंगे ना, भाई तुम इतना खर्चा कर कुछ है, तुमने कहाँ दूसरे हॉस्पिटल में किया, क्या फीडबैक है, अपन अपनी ड्यू डिलीजेंस करेंगे. इफ यू आर सेटिस्फाइड विद दैट एजेंसी, प्लीज गो हेड.
So how many tables they can put in an OT?
1
Depending on size,
irrespective ऑफ साइज.
irrespective, 20 by 40. But
आप यार 100 बाय 100 का ओटी बना लो, टेबल एक आएगी. सिर्फ और सिर्फ 2 टेबल जाएंगी ट्रांसप्लांट ओटी में. किडनी ट्रांसप्लांट है, कुछ है जहाँ पे अपन ट्रांसप्लांट करते हैं ना, देयर द 2 टेबल्स आर देयर. एक्सेप्ट फॉर दैट, जिस भी साइज का ओटी है, टेबल एक ही रहेगा. Oh madam, this is last session. Whenever they say okay, we are okay. हमारी तो फ्लाइट लेट.
tables I think he's asking because he wanted to do one cataract के other cataract.
यार करो ना, NABH मत लो. देखो लाइफ में हर चीज का सोल्यूशन है, अपन मानते नहीं है सोल्यूशन को. मैं तो ये बोलूँगा, तुम्हें 2 टेबल चलाना ना, मैंने भी 3 टेबल में ऑपरेट किया यार. बट
NABH पे मत जाओ.
हाँ, अपना करो ना, तुम 2 डालो 4 डालो, जो करना है करो. किसी को